This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, my name is Dr. Rob Page and welcome to Doc Talk. Doc Talk is a podcast that's produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that is helpful in terms of making their healthcare decisions. I feel very fortunate to have with me today Dr. Ryan Schmoker. Dr. Schmoker is a surgical oncologist at the University of Tennessee, and he specializes in the area of the treatment of pancreatic disorders and more specifically pancreatic cancers. Welcome back.
Thank you. It's good to be back.
Excellent. We had spoken sometime before about some of the risk factors and some of the issues, and if you're interested about being vigilant about pancreatic cancer, please look for the other podcast that's featuring Dr. Schmoker. This time we're going to be speaking more about the treatments that are actually now available for pancreatic cancer. You and I talked briefly when I came in, and I just know that that when I was in medical school a while ago, and when I was doing the rounds, there was not a whole lot that was available in terms of treatment for pancreatic cancer, other than very extensive surgeries. I just remember there's one of the things you learn in medical school with the chevron sign. You could always tell who'd had the surgery because they had the largest surgical scar. But you're here to tell us today that there's a lot more that exists on the horizon, that actually the prognosis for patients with these cancers is much better, and that there's a variety of different things that can be done for these patients, especially in this area. Well, now I'll say welcome.
Thank you. Thank you.
So first of all, tell us about your area of expertise and how you typically treat patients. And if you're a patient who presents to, if you're a patient, and so a patient presents to you with pancreatic cancer, how would they typically be worked up? What sort of, because I would imagine that typically they come to you possibly with already a diagnosis or maybe with a mass. Anyway, if you could talk about that as well, that would be great.
Yeah, so I specialize basically in GI surgical oncology. So I do everything from pancreas to liver to gastric cancer, bile duct cancers. The one thing I don't tend to do a lot of is colon cancer these days, but But the majority of the patients that I see are patients with pancreas cancer or other pancreatic masses. And it can be a wide variety, actually, of how patients show up in general. They've had some sort of workup, including laboratory values, CT scans, things like that. But pancreas cancer can be a very challenging cancer to diagnose with biopsies. And so it is not infrequent that a patient shows up in my clinic with a pancreatic mass that we're not entirely sure what it is yet. And so at that point, then I sort of take over and we figure out how to either get a diagnosis or what the next best steps are.
So typically, so continuing along that line, what are the next steps?
So a lot of times we will try to biopsy again with what's called an endoscopic ultrasound. It's an ultrasound that actually goes on the end of an endoscope, and they can drive down and actually use that ultrasound and make sure that they're putting the needle right in whatever mass we're concerned about. Sometimes we do that procedure multiple times and still don't get an answer, and then we have to have a really frank discussion about potentially doing a big cancer surgery and not knowing for sure whether this is a cancer or not. And part of that discussion is a little bit what I wanted to talk today about is the multidisciplinary approach to a lot of these patients. And what I mean by that is patients, we have several different tumor boards or groups where we meet and talk about patients that either have problems that have multiple potential treatment options or we're not sure of. And those groups include people like myself who are surgeons, people who are medical oncologists, meaning chemotherapy doctors, radiation doctors, the radiologists who actually go through the scans with us and help us sort out exactly what's going on. Things like the pathologists, if we have a diagnosis, and help us sort of that piece of the thing, and things like genetics and clinical trials and things like that.
So intrinsically, this is so pancreatic cancer, much like we do know a lot about other cancers, is not sort of a one size fits all.
Correct.
This is not you're not a patient. You come in, you typically get the it's not because you're a surgeon, you're not necessarily going to get a surgical therapy for it. That there are other ways available, and a lot of this is tailored toward not only that, but possibly where the patients live, or how old they are, how healthy they are, a variety of other factors. I would venture.
Yeah, so every patient gets sort of a customized approach that takes into all of those factors, things like the characteristics of the tumor itself, health status, comorbidities, a whole bunch of things like that. And I really think that's the primary benefit of having multiple minds in the same room coming up with the best plan for that individual patient.
Gotcha. And so it's a great way to be able to synthesize all the information in one room and not have to pass it around and pass back and forth, which would take a very long time. So you talked about adjuvant therapy. So you've been diagnosed with a pancreatic cancer. You possibly may or may not have surgery. Well, first of all, what do you mean by adjuvant? And second of all, what's available to these patients?
Yeah, so pancreas cancer is undergoing a really sort of rapid evolution. So for patients that have a pancreas cancer that isn't pushing on any of the big blood vessels, don't have a lot of big lymph nodes or things like that, in the old days, patients would get surgery, and then after surgery, they would get chemotherapy for 6 months. It started out, about 10 years ago with a single drug, and as we've learned more about combining the chemotherapy drugs, we now have regimens that are 2 or 3 chemotherapy drugs, and what we know is those patients do much better. The real sort of shift in maybe the last 5-ish years or so is that a lot of times we're starting to push that chemotherapy up even before surgery. And there's a number of reasons for that. One is that this is a big surgery. About half of people have some sort of hiccup in their recovery, and we know that they need chemotherapy, and as we delay it for complications after surgery, we know that those patients don't do as well. For the other thing is that for the vast majority of patients, there are some cancer cells that have escaped from their primary tumor, and by treating those early, our hope is that we, by the time we get to surgery, all of those cancer cells that are other places are dead, and that what's left is the primary tumor, and we actually can offer patients potentially a cure with surgery.
So in addition to chemotherapy and surgery, are there any other therapies that are available out there now?
Yeah. There are. So for many patients, we talk about, at least discuss using radiation therapy.
Okay.
And we tend to use that fairly frequently for patients where the tumor is pushing on some of those big vessels or close to the big blood vessels, or they have big lymph nodes that we're a little bit concerned about. In addition to sort of the traditional chemotherapy, the chemotherapy that you sort of think about as far as hair loss, fatigue, things like that. Some patients actually are candidates for either targeted therapies, so targeting a specific mutation, or some patients, and it's not a lot for pancreas cancer like it is for things like melanoma and things like that, but it can be candidates for even immunotherapy.
So when you talk about genetic mutations and specific treatments, are there specific genetic mutations that exist in pancreatic cancer?
Yeah, so there are both familial mutations and then mutations within the tumor itself. And so when we think about familial mutations, we think about things like BRCA1 and 2.
Okay. Which is more commonly, so we think about that with breast cancer, right, or ovarian cancer,
Correct.
But also in pancreatic cancer.
Also in pancreatic cancer. Things like familial colorectal cancer, some of those have pancreas cancer susceptibilities, and people who have pancreatitis or hereditary pancreatitis actually have an increased risk of pancreatic cancer. On the other side, many of the tumors, about a quarter of patients have tumors that are actually susceptible to targeted therapies, so not your traditional cytotoxic chemotherapy, but actual drugs that target the mutation specific to their cancer.
And one of the things you told me, which I thought was pretty exciting, is that in terms of success stories, we've gotten pretty good at treating a lot of diseases, but pancreas, it's a horrible disease, but you were telling me that the field has pretty much changed for these patients in terms of the survivability and the mortality and morbidity of having the disease.
Yeah, we still have a long way to go, but we have made a lot of progress in the last 20 years, both from quality of life for the patients who may have advanced disease or things like that. We are much better at using sort of lower dose chemotherapies or changing the chemotherapy regimens that actually can improve quality of life, but we're also better with palliative care, managing symptoms, making sure that patients are meeting their nutritional goals and things like that. And so even for the patients who we're not shooting for a cure for, we are much better at treating them in general.
And you mentioned to me a couple of numbers which really struck out in my mind. Which really stuck out in my mind. One of them was had to do with the mortality about just the surgical procedure itself, and the overall survival, or at least 5-year survival in these patients.
Yeah, so in the last 20 years, we've gone from about a 5.5% overall survival for all patients with pancreas cancer to about 10% in
So
2021.
doubled, which is amazing, yeah.
And then when patients are candidates for surgery, our mortality has gone from 30%, as recently as the 70s and 80s to about 1 to 2%.
Wow. So a surgery that was really associated with a lot of, perioperative mortality is now not so much anymore.
No, it's not. And a lot of that is the systems we have built, but it's also that we have a lot more experience and are a lot better at anticipating problems and addressing those.
That's incredible. So I mean, and a lot of that just is, to me, fairly amazing, because needless to say, when I was in school, it was not. I mean, there was not a whole lot that was available except for really extensive surgeries, and there were very few people who could do those very well. I mean, you had people who did them, but it's nice to know that we have somebody who's local who actually is available to patients, so they wouldn't necessarily have to go to an MD Anderson, possibly, or to Memorial Sloan Kettering to get these really big cancer surgeries, that they're actually done here locally.
Correct.
So with that in mind, can you give us, if we have anybody who's watching who's interested in getting more information about pancreatic cancer, or even any of the gastrointestinal cancers, or some of the other things that you also treat, where would they go online to go look for this?
Yeah, so you can either Google my name, and it'll be the first hit, or I am part of a group called University Surgical Oncology at the University of Tennessee Medical Center. Very easy to find if you look.
It's near the stadium, I hear.
It is.
So, and we'll have all that information at the bottom of the screen for you patients who are interested in contacting Dr. Schmoker, be it for pancreatic cancer, or even for other members of his group who treat other forms of cancer, or other forms of gastrointestinal malignancy that you also treat in your practice as well.
Yeah, and I would like to make one little plug. As I've started at UT, we are starting to employ a lot of minimally invasive techniques for some of these big cancer surgeries, including robotic approaches and things like that. Certainly, the days of an incision from your breastbone down to your pelvis are going away.
Yeah, that's it. And you also mentioned one other thing, which I think has been an excellent development, which you don't necessarily have to have a surgical procedure to have a diagnosis made. That's done endoscopically, so a patient could come in, have the procedure done, and go home, possibly the same day, because there's no incisions that need to be made.
Correct.
So not only are there better surgical procedures, but also ones that we know about. Some of the stuff we talked about, robotics, and some of the other doc talk that I've done, and about its availability for lots of different surgeries, and it lessens the amount of time that patients have to remain in house, and a lot of other things. Is that correct?
Absolutely, and one of the big things we worry about when we have to make big incisions to do these operations is things like wound infections and hernias and things like that also go way down.
So a lot of the the complications that might be associated with it are decreased, and hospital times can be decreased.
Correct.
So many different things are so much better now that we can do it with these, with very precise surgical instruments. Not that you're not precise, but I mean, it's just, when you think about sort of the robotics and the way that they can move, it's just unbelievable stuff.
And it's magnified 3 times. That's better than my eyes. So.
That's right. It's certainly better than mine. So anyway, well, Dr. Schmoker, thank you so much for coming here today and giving us information about some very hopeful things that have occurred in the area of pancreatic cancer treatment and adjuvant therapy, and the fact that we have someone available to us locally who can actually provide treatment. So we wouldn't necessarily, if the patient perhaps needs it, maybe to go somewhere else, but at least it's available locally, and you wouldn't necessarily have to go somewhere else to get treatment that we have here locally here in the Knoxville area.
Absolutely.
So anyway. And with that, that brings this episode of Doc Talk to an end. Doc Talk is a podcast that's produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that are important in terms of making their healthcare decisions. I'm Dr. Rob Page, and thank you so much for joining us.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.